Hello to all of you. Myself Dr. Shilpi Agarwal. Today we will be discussing the anatomy questions of Grand Test 183. The questions are from 177 to 193. We will start with the first question, that is question number 177. The question number 177, it says that the embryological first pharyngeal arch remain or the derivative is. In this, the answer for this question is A. The answer for this question is A. The sphenomandibular ligament, this is the structure which develops from the first arch, and the styloid ligament it develops from the second arch. The stylomandibular ligament, it is simply a thickening of the deep cervical fascia which extends from the styloid process till the angle of the mandible. Now in this, if you see various derivatives of the first arch and the second arch, so the derivatives of the pharyngeal arches, the first arch. Now when we talk about the first arch, it is giving rise to the various bones, ligaments and the muscles, then it is having a nerve and artery. Now the bones which develop from the first arch, these are maxilla, mandible, zygomatic bone and part of temporal bone. These are the bones which develop from the first arch. The cartilage from which it is developing, or the cartilage which is formed by the first arch, is a Meckel's cartilage. Now the ligaments which are formed in these bones, along with these bones, the two ear ossicles, they also develop, that is malleus and incus. Then the ligaments which are developed from the first arch, it includes the anterior ligament of malleus, then the sphenomandibular ligament. Now we know that these arches, these are arranged just on either side of the oral cavity. So they are arranged from above to below like this. The first, second, third, fourth and then the sixth. The fifth arch, it actually disappears. So if you see the derivatives of the first arch, it is giving rise to the maxilla, then to the zygomatic bone, the mandible is formed and the part of the temporal bone is formed, in which it is also giving rise to the spine of sphenoid. Now the ligaments which are attached to these bones, one ligament is the anterior ligament of malleus, another ligament is the sphenomandibular ligament. These are also derived from the first arch. The sphenomandibular ligament, it begins from the spine of sphenoid and it goes and gets attached to the mandible. The muscles which are formed by the first arch, it includes the muscles of the mastication. In the muscles of mastication, we have masseter, the medial and the lateral pterygoid and the temporalis muscle. Apart from this, we have anterior belly of digastric and the mylohyoid muscle. Then the two tensors, that are tensor villi palatini and the tensor tympani muscle, these are also developing from the first arch. So these are the structures which develop from the first arch, and if we talk about the nerve of first arch, the nerve of first arch is mandibular nerve. And because it is a nerve of first arch, it will be supplying all these muscles which are developing from the first arch. So all these muscles are supplied by the mandibular nerve. The artery of the first arch, the first aortic arch, though it is having a very small remnant or very small artery is developed, and it leads to the formation of maxillary artery. So all these structures, these are the derivatives or are derived from the first arch. Now if we talk about the second arch, from the second arch, the cartilage which is formed is the Reiter's cartilage. The Reiter's cartilage. Then the bones which are formed, it includes the stapes bone, which is one of the ear ossicle, then the styloid process. Apart from this, now it will be leading to the formation of a bone which is present over here at the junction of the floor of the mouth and the neck, and this bone over here is the hyoid bone. So because this second arch is present above, it will be leading to the formation of the uppermost structures of the hyoid bone, which includes the lesser cornu and the superior part or the superior half of body of hyoid bone. So all these structures, they are derived from the second arch. Now if we talk about the ligaments, the ligament which are derived from the second arch, it includes a ligament which is attached to the styloid process as well as to the hyoid bone, that is the stylohyoid ligament. The muscles, again a muscle which is attached to the styloid process, and to the other end it is attached to the hyoid bone, that is the stylohyoid muscle. Then a muscle which is the muscle of the tympanic cavity, that is the stapedius muscle. Apart from this, the posterior belly of digastric and the facial muscles. All these muscles, they are derived from the second arch, and if we talk about the nerve of second arch, that is the facial nerve. So this facial nerve now will be supplying all these muscles. The artery of the second arch, it is the stapedial artery, as well as it also includes hyoid artery. So this arch, this aortic arch is also giving rise to an artery which is of smaller lumen or smaller diameter and not a large artery. So stapedial artery and the hyoid artery. This is from the second arch. Now when we talk about the third arch is giving rise to minimal structures. It is giving rise to one muscle only and the rest of the portion of the hyoid bone, which we have just discussed. So it leads to the formation of the rest of the portion of hyoid bone, that includes the lower half of body as well as the greater cornu of hyoid bone. Now the muscle, a single muscle is developed from here, that is the stylopharyngeus muscle. The stylopharyngeus muscle is also formed. The nerve for the third arch is glossopharyngeal nerve. And this is the nerve which will be now supplying the muscle which is derived from the third arch, that is the stylopharyngeus muscle. Now when we talk about the artery which develops from the third arch is giving rise to the common carotid artery and the internal carotid artery. Of the right and the left side. Right and the left side. So these are the derivatives of the third arch. Now the fourth and the sixth arch, they together are forming the muscles of the larynx and the pharynx as well as the cartilages of larynx. Now if you see them, the fourth arch, it gives rise to the cartilages of larynx except the cricoid and arytenoid. Apart from this, it is also giving rise to the muscles. It is giving rise to the muscles of pharynx, then the muscles of the palate, and the cricothyroid muscle. The fourth arch is giving rise to all the muscles of the pharynx except the stylopharyngeus, which is actually derived from the third arch. Then giving rise to the muscles, all the muscles of palate except the tensor villi palatini, which is taking origin from the first arch. Then it is giving rise to one of the laryngeal muscles, that is the cricothyroid. The nerve for the fourth arch is a superior laryngeal nerve. It is a superior laryngeal nerve which is a branch of the vagus nerve only, and if you see the artery which is derived from the fourth arch, it is different on right side and on the left side. If you see towards the left side, it is contributing to the formation of the arch of aorta, and towards the right side it is contributing to the formation of right subclavian artery. So all these are the structures which are derived from the fourth arch. Now we come to the sixth arch. The sixth arch is giving rise to the rest of the cartilages, that is cricoid cartilage and the adenoid cartilage. Apart from this, it is giving rise to all the muscles of larynx except the cricothyroid. Now the nerve for the sixth arch. The nerve for the sixth arch is recurrent laryngeal nerve, which is again a branch of the vagus nerve. And if we talk about the artery which develops from the sixth arch, it is the pulmonary arteries, the right and left. And apart from this, on the left side, it is also giving rise to the ductus arteriosus. So all these are the derivatives of the pharyngeal arches. Now we come back to another question, that is 178. Next question is question number 178. It says that which of the following is derived from both ectoderm and the mesoderm. So if we see in this, the structure which is derived from both ectoderm and mesoderm, the answer will be the suprarenal gland. The suprarenal gland is the one it is having two portions, the adrenal cortex and the adrenal medulla. The cortex is the one which is developed from the mesoderm, and medulla is the one which is developed from the ectoderm. The medulla portion, the adrenal medulla, it actually develops from the neural crest cell, which is derived from the neuroectoderm. So we say that the adrenal medulla, it is derived from the ectoderm. And the cortex portion, it is derived from the mesothelial cells which are present in the coelomic cavity. So we say it is derived from the mesoderm. When we talk about the cortex, the adrenal cortex, at around 4th week of intrauterine life, the cortex, it starts developing from the mesothelial cells which is present in the coelomic cavity. The mesothelial cells, they proliferate to form small buds which will later on give rise to this cortex region. Then at 6th week of intrauterine life, this adrenal cortex is formed. So we say the fetal cortex. The fetal adrenal cortex is formed. And this will later on form the adult cortex. It will regress later on to form the adult adrenal cortex. So at birth, the adult adrenal cortex is formed, which includes the zona glomerulosa layer as well as the zona fasciculata layer. At 3 years of age, the third layer develops, that is the zona reticularis. So the cortex, it develops from the mesoderm. Now when we talk about the medulla, it is actually developing from the neural crest cells. The neural crest cells, they migrate towards the coelomic cavity and they go inside deeper to the adrenal gland and they form the deeper portions of the adrenal gland, which is termed as the medulla. And these they consist of specifically the chromaffin cells, and the chromaffin cells, they actually get their name from the color they get when they are stained by the chromium salts. They actually stain yellowish brown, so therefore it gets its name, the chromaffin cells, and it is developed from the neural crest cell, which is neuroectodermal in origin. So we say it is ectodermal. Now if you see the rest of the options, it includes kidney. When we talk about the kidney, it is having a collecting portion and a portion which is a conducting portion. So the main portion or the parenchymatous portion of the kidney, it is formed by the metanephric blastema, which is mesodermal. The metanephric blastema, it is formed from the intermediate mesoderm. So it is mesodermal in nature. It gives rise to Bowman's capsule, the loop of the Henle, the PCT, DCT and the collecting tubules. The rest of the portion of the kidney, it is formed by the ureteric bud. Now the ureteric bud, it is actually derived from the mesonephric ducts, and therefore because the mesonephric duct, it is also mesodermal in nature, the ureteric bud is also mesodermal in nature. The ureteric bud is the one which will give rise to the ureter, to the major and the minor calyx, as well as to the collecting ducts. So these two structures, they are giving rise to the whole of the kidney, and over here we can see that they are mesodermal in nature. Both the structures are mesodermal in nature. Another option which is given over here is the pancreas. When we talk about the pancreas, it is developed from the pancreatic buds, which are the dorsal and the ventral pancreatic bud. These two buds, they give rise to the pancreas, and these two buds, they are actually budding out from the foregut. And the foregut, as we know, it is endodermal in nature. So the pancreas, it is derived from endoderm only. It is derived from the endoderm. Now the next option which is mentioned over here is the spleen. The spleen, it is actually derives from the mesodermal cells which are present in the dorsal mesogastrium. So spleen is mesodermal in nature. So therefore in this we can see, out of these four options, the suprarenal gland is the one which is having two origins, and those are from the ectoderm as well as from the mesoderm. So the answer for this is the suprarenal gland. We come to the next question, question number 179. In this we have to choose the incorrect statement about the marked folds. If we see over here, this picture is actually showing the sagittal section. This is the sagittal section of the head and neck, and it is focusing towards the posterior portion of the sagittal section. This portion is the nasal cavity. The posterior portions of the nasal cavity, and this portion over here, this is the oral cavity. The posterior portions of oral cavity. This is the soft palate. This is the soft palate, and posterior to it we are having the pharynx region. Now if you see the options over here which have been mentioned over here, A, B, C and D, we will identify these structures. Over here there is the opening of the auditory tube. And there is an arch which extends anterior to it and posterior to it. The arch which is going anterior to it has been marked B over here, and the arch or the pillar which is posterior to this opening is marked A over here. So A, this fold, it is actually having a muscle deep to it, which is the palatopharyngeus muscle. Sorry, this is the salpingopharyngeus muscle. This is the salpingopharyngeus muscle because it is coming, it takes origin from the auditory tube only, the cartilaginous part of auditory tube. The salpingopharyngeus muscle, A is salpingopharyngeus muscle, B over here, this portion over here, this fold, it has a muscle deep to it which is the levator velar palatini muscle. So B is levator velar palatini. If we come below the soft palate, this is the oral cavity and this is the tonsillar fossa where the palatine tonsil is present. Again there is a fold which is anterior to it and another fold which is posterior to it. If we see, this is the anterior fold or the anterior pillar of this tonsillar fossa and this is the posterior fold or the posterior pillar. The anterior pillar or the anterior fold, it is marked C over here and it has a muscle deep to this fold which is termed as palatoglossus. The D structure over here, it consists of the muscle which is palatopharyngeus. The portion over here, this is the tongue. So we have identified the various structures which are present over here, the opening of auditory tube, salpingopharyngeus, palatoglossus, palatopharyngeus and levator velar palatini. Now if we come back to the question says the option A is the muscle deep to A. The muscle deep to A, that is the salpingopharyngeus, it is supplied by the cranial root of the 11th nerve. Now we know that this cranial root of the accessory nerve, it is actually contributing to the formation of the vagoaccessory complex which forms the pharyngeal plexus and it will be supplying the various muscles of the palate as well as the various muscles of the pharynx. So this muscle which has been mentioned over here, salpingopharyngeus, it is being supplied by this cranial root of the 11th nerve. All the muscles of palate they are supplied by vagoaccessory complex This vagoaccessory complex, it includes the vagus nerve and the cranial root of the accessory nerve, all except the tensor villi palatini. So therefore the salpingopharyngeus muscle, which is one of the muscle of the tensor villi palatini. Apart from this, all the muscles of pharynx they are also supplied by the vagoaccessory complex. All except the stylopharyngeus. So the salpingopharyngeus, which has been mentioned over here, is one of the longitudinal muscles of the pharynx, and therefore it will be supplied by this vagoaccessory complex, or we can say by the cranial root of the accessory nerve. Now these muscles, the tensor villi palatini, it is actually supplied by the mandibular nerve, and the stylopharyngeus, it is supplied by the 9th cranial nerve, that is the glossopharyngeal nerve. So if we come back to the question, that means that this option is correct. The next option is muscle deep to B is tensor villi palatini. The muscle deep to B, as we have already discussed, is the levator villi palatini. So this option is not correct. Then mucosal fold C, the C which we have already told that the palatoglossus, it forms the anterior pillar for the palatine tonsil. This is correct, as we have just discussed. The muscle deep to D, that is the palatopharyngeus, is inserted to the posterior border of thyroid lamina. This is also correct. When we talk about the muscles of pharynx, it is having 3 circular muscles and 3 longitudinal muscles. The three circular muscles, they are the superior, middle and inferior constrictor. Then the three longitudinal muscle, it includes the salpingopharyngeus, palatopharyngeus and the stylopharyngeus. These are the three longitudinal muscles. Now when we talk about these three longitudinal muscles, the salpingopharyngeus, as the name suggests, it begins one of the attachment is to the salpinx, that is to the auditory tube. Another attachment is from the salpinx, it comes down below, it travels longitudinally below and it will be forming one of the muscles of pharynx. Another is palatopharyngeus, so it arises from the palatine aponeursis or from the posterior most border of the hard palate, and then again it comes below and it is running vertically downwards, forming a longitudinal muscle of the pharynx, and again it is going and inserted at one point. The stylopharyngeus, it is taking origin from the styloid process. Now a characteristic feature about these three muscles is that they are taking origin from three different points, but they come together, and all these three muscles, they are inserted at one common point, and that is at the posterior border of the thyroid lamina. So they have a common insertion on the posterior border of the thyroid lamina. So posterior border of lamina of the thyroid cartilage. So therefore we can see over here the last option which has been mentioned, it says that the palatopharyngeus muscle, which is marked as D over here, it is having insertion over the posterior border of lamina of thyroid cartilage. So the last option is also correct. Now we come back to the question. So where we have seen C A D, it is correct, and A is also correct. Only the B is the one. The B structure, B is the one which is incorrect. So the answer for this question is B. Now the next question is question number 180. The question number 180 says that umbilical arteries, they arise from which fetal vessels? The answer for this question is D. Now how is this answer? We will just discuss. When we talk about the fetal circulation, now the fetal circulation is different from the adult circulation because it is having the presence of umbilical artery, then umbilical veins, the ductus venosus and the ductus arteriosus. These are the structures which are not present in the adults, or only the remnants are present in the adults. So when we talk about the fetal circulation, the blood from the placenta, in the placenta the oxygenated blood is there, and this oxygenated blood is brought to the fetus with the help of the umbilical veins. The left umbilical vein, it brings the oxygenated blood from the placenta towards the fetus. So if you see over here, if this is the placenta and this is the umbilical cord which is attached to the umbilicus over here, it is carrying the umbilical vessels, which includes one umbilical vein, and another is it is having two umbilical arteries. So the umbilical vein, the blood from the umbilical vein, this is a vessel which is coming from here, this is the left umbilical vein, it reaches towards the liver and it bypasses the liver, or it passes through the liver via the ductus venosus, and the blood from the umbilical vein, it reaches the inferior vena cava through this ductus venosus. So there is a channel over here which is termed as ductus venosus, and then it reaches the inferior vena cava. So this is left umbilical vein, This is the ductus venosus, which is present in the liver, and this is the inferior vena cava. The blood is, oxygenated blood is coming from the placenta and it is reaching towards the inferior vena cava. Now after this, as we know the inferior vena cava, the blood from the inferior vena cava will reach towards the right atrium, and in the fetus, the majority of the blood in the right atrium reaches towards the left atrium through the foramen ovale. So if you see the heart over here, if we draw a schematic diagram over here, this is the right atrium, this is the left atrium, right ventricle, left ventricle. There is an oblique opening over here which is present in the interlateral septum, and this is termed as now the blood which is coming from the inferior vena cava, it will come through the inferior vena cava and will reach towards the right atrium. Now from the right atrium, this blood will pass through the interatrial septum. The majority of the blood it passes through towards the left atrium, and only the minor amount of blood it reaches towards the right ventricle. So the blood which reaches, the majority of the blood which is reaching the left atrium, now it will go towards the left ventricle, and from the left ventricle it will pass towards the aorta. Now the minor amount of the blood which is reaching the right ventricle, it passes through the pulmonary trunk, but because the lungs are not functional in the fetus, this blood needs to be bypassed, and the blood which reaches over here in the pulmonary trunk or the pulmonary artery, it will be passing through the ductus arteriosus towards the aorta. So the right ventricle, the blood it goes towards the pulmonary artery, and this blood it passes through the ductus arteriosus towards the aorta. Now the aorta, when it gives off its branches, the subclavian arteries, the common carotid arteries, the oxygenated blood is distributed to the head and neck portion and to the limbs. Now further, the blood from the aorta, we know the blood is now flowing down through the aorta. This is the aorta. It gives further branches, the descending aorta is giving branches, the abdominal aorta is giving branches, and the whole of the blood is distributed throughout the body. Now when it reaches towards the lowermost portion of the trunk, it will terminate into the common iliac artery. And the common iliac artery now will again divide it into external iliac and the internal iliac. This is the external iliac artery. The external iliac artery, it will continue as a femoral artery, and therefore the blood is distributed to the lower limbs also, and through the internal iliac artery the blood is going towards the pelvic cavity. So from the aorta, now the flow of the blood is in this direction like this. This internal iliac artery, it gives one of the branches, that is the umbilical arteries in the fetus, and these umbilical artery on the right as well as of the left side, they will now go towards the umbilicus and will run through the umbilical cord back to the placenta. So now a branch arises from the right side as well as the left side of internal iliac artery, and this is forming the two umbilical arteries, the right and the left umbilical arteries. And now they will go back towards this umbilical cord, and the blood will go towards the placenta again for the oxygenation. Now over here, this is the complete fetal circulation. In this, these structures, the umbilical vein, they will become remnant in the adults, and it will lead to the formation of the umbilical vein. It leads to the formation of ligamentum hepatis teres. The ductus arteriosus, it leads to the formation of ligamentum arteriosum. The ductus venosus, it leads to the formation of ligamentum venosum. And when we talk about the umbilical arteries, the proximal part of the umbilical artery, it is patent, which leads to the formation of the superior vesical artery, and the distal part, it forms a ligament which is the umbilical ligament. The medial umbilical ligament. These are the remnants which are present in the adults. Now by this whole picture we can see the right and the left umbilical arteries, they are actually rising from the internal iliac artery, and this is the answer for the question. Now we come back to the question. The question says the umbilical arteries, they arise from which fetal vessels, and the answer is the iliac arteries. Now question number 181. The question number 181, it says that superior thyroid artery, it is a branch of the external carotid artery. The external carotid artery, it is one of the terminal branch of the common carotid artery. The common carotid artery, it arises from the arch of aorta. Now if we see in the face that how there is the distribution of the external carotid artery. This is the common carotid artery, and this divides into external and the internal carotid artery, and this division is at the level of the upper border of the thyroid cartilage. So if the thyroid cartilage is present like this over here, at the upper border of the thyroid cartilage, the common carotid artery divides into the external carotid and the internal carotid artery. This one is the external carotid. The external carotid artery, now it will go towards the face and it will be giving the various branches. Now the first branch which is given by it goes towards the thyroid gland. So over here this first branch, it goes below, and this first branch is the superior thyroid artery. This is the first branch, as well as this is the anterior branch of the external carotid. Then another branch which is given from the anterior aspect of the external carotid, it goes towards the oral cavity, and this second branch is the lingual artery. The third branch, again arising from the anterior aspect, it goes towards the face till the medial canthus of the eye. This is the third artery, which is the facial artery. This facial artery, when it is going towards the face, it is giving the superior labial artery and the inferior labial artery, as well as the lateral nasal arteries. These are superior and inferior labial artery, and this one is the lateral nasal artery. This facial artery, apart from these arteries, it is also giving the tonsillar artery and the glandular arteries. The tonsillar artery is the one which is the main artery for the palatine tonsil. Now all these three, first, second and third, these are arising from the anterior aspect, and these are the anterior branches. Then we have the branches which are towards the posterior side. This artery which is going towards the occipital region, this is the occipital artery. Then one more branch which is going towards posterior side, posterior to the ear. This is the fifth branch, which is posterior auricular artery. So we have two posterior branches. Apart from this, one medial branch is there. There is a branch which goes towards the medial side, which is going towards the medial side, and this sixth branch is ascending pharyngeal artery. This is the medial branch which is going towards the pharynx. Now as this external carotid artery is going above towards the face, it passes through the substance of the parotid gland, which is present over here. So the parotid gland, it is present over here. and this artery is passing through the substance of parotid gland, and within this over here only it gives two terminal branches. First is the maxillary artery and another is superficial temporal artery. This is 7th and 8th. The 7th is maxillary artery and the 8th is superficial temporal artery. These two are the terminal branches of the external carotid. So all these are the branches of the external carotid artery. The internal carotid artery over here, it does not give any branch in the neck. It passes through the carotid canal. The carotid canal is present in the base of the skull, then it enters the cranial cavity, and after it enters the cranial cavity, then it will be giving the further branches. So towards the outer aspect or towards the external side, the external carotid is the one which is giving branches to head and neck system. So as the question says over here, the superior thyroid artery, it is a branch of the external carotid artery. So you come back to the question, answer is C. Now the question number 182, the question number 182 says that which structure is attached directly to the free margins of mitral and the tricuspid wall. Now over here the answer will be B, the chorda tendineae. Now if you see towards the interior of the ventricles, specifically if we see the right ventricle, the interior aspect, now in this we remove a wall of the right ventricle so as to see the structures which are present inside it. This is the right atrium and this one is the right ventricle, and this is the site where the cusps are present. The cusp of the tricuspid wall, and if you see over here, there are three cusps of the tricuspid wall. This one is the anterior, this one is the posterior, and this one is the septal. Now towards here, towards the inner aspect, we are having the papillary, the trabecular carne, the wall of the ventricles, it is having muscular ridges which are termed as trabecular carne. Now the trabecular carne, they are divided into ridges, bridges and the pillar. This is according to the arrangement of the muscle fibers within the ventricles. The ridges, they are simply the linear elevations, the elevations which are present within the ventricle. They appear like this, small elevations. The bridges are the one which on either side are attached to the wall, the ventricle wall, and on the middle it is free. The pillars, these are the longer or the most prominent muscular structures of the prominences which are present, and this is also termed as papillary muscle. Now there are three pillars or three papillary muscles in the right ventricle and two are there in the left ventricle. So if you see in the right ventricle, there are three: the anterior papillary muscle, then we have the posterior and the septal. Among this, the anterior is the one which is the largest. In the left ventricle, we are having two, the anterior and the posterior. So if you come back to this picture, this is the anterior papillary muscle and over here the posterior papillary muscle, and this is the septal papillary muscle. Now these papillary muscles, they are attached to the free margins of the cusp with the help of thread-like structures which are termed as cauda tendineae. These thread-like structures, they are termed as cauda tendineae. Apart from this, there is one more structure which is present in the right ventricle, and it is the presence of the moderator band. This is the moderator band. The moderator band, it is extending from the interventricular septum towards the anterior papillary muscle, and this is the one which is actually consisting of the right branch of bundle of His, and it is specifically termed as moderator band, or it is also termed as septomarginal band. Now over here we can see, according to the question, the cauda tendineae is the structure which is giving or which is attached to the free margin of the cusp of the tricuspid, as well as the same structure is present towards the left ventricle also. So over there it will be attached to the two cusps, the anterior and the posterior cusp of the mitral wall. So if we come back to the question, answer is B, that is cauda tendineae. Next question, question number 183. In this we can see we have to identify the nerve palsy which is associated with this over here, and if we specifically see over here, the position of the hand is like this, in which we are actually pinching the index finger and the thumb. Now in this what actually happens when we are pinching the index finger and the thumb, if there is ulnar nerve palsy, then the adduction function is substituted by the flexor movement by flexor pollicis longus, and in that way there will be a flexion of the thumb which can be seen like this. So normally we have the pinching movement like this, and if there is a flexion of the thumb over here which is substituting the adduction function, then we say that the ulnar nerve palsy is there, the adductor pollicis is involved, and this its function is taken over by the flexor pollicis longus. And same thing can be seen over here. If you see, in this hand the flexion of the thumb is there, which is by the flexor pollicis longus, and it is helping in this kind of movement, and this shows that there is ulnar nerve palsy. The same fundamental thing is used when we are testing the Froment sign. In the Froment's books test, we put, if for example this is the book, we put the book between the index finger and the thumb, and we try to pull the book. So if you are pulling the book like this, normally the thumb is adducted, the adduction of the thumb, it will help or it will resist the pull of this book. But in the ulnar nerve palsy, because the adductor pollicis is not functional, the thumb it gets flexed with the help of the flexor pollicis longus, and it prevents the pull of the muscle. So in that the flexor pollicis longus which is intact, it is acting, and this shows that the Froment sign is positive. So the sign is like this in that. So when we talk about the ulnar nerve, this is the humerus, and this is the medial epicondyle of the humerus. The ulnar nerve, it passes behind this medial epicondyle. We know that the ulnar nerve, it is actually arising from the medial cord of the brachial plexus. It is one of its branch. And its root value is C7, C8 and T1. Now as it reaches the forearm, In the forearm, it is actually passing between the two heads of the flexor carpi ulnaris, and it forms a kind of cubital tunnel over there. If the nerve is compressed over there, we use the term cubital tunnel syndrome. This is at the wrist, we are having the flexor retinaculum. The nerve, it gives supply to two muscles in the forearm, then it passes superficial to the flexor retinaculum so as to reach towards the hand. In the hand, it is giving superficial branch and a deep branch. In the forearm, it is giving supply to flexor digitorum profundus, the medial half, and along with that it is giving supply to flexor carpi ulnaris. And as it reaches the hand, as we have told, that it gives a superficial branch and a deep branch. The superficial branch is supplying the palmaris brevis, as well as it gives the cutaneous branch, which will be supplying the skin of the hand. And the cutaneous branch, it is actually supplying the medial 1.5 fingers and the adjacent palm. It is supplying the medial 1.5 fingers. The deeper branch, it supplies all the muscles of the hand except the first and the second lumbrical and the 3 thenar muscles. So if you see over here the muscles which are supplied by the deep branch, it includes one of the thenar muscle, that is the adductor pollicis. Then it supplies the hypothenar muscle, the 3rd and 4th lumbrical, and all the interossei. So all these muscles, they are supplied by the ulnar nerve. Now to test the ulnar nerve, we have 3 tests so as to test this. One is the Froment's book test. Then we have paper test. And third is the Ogawa test. As you have just discussed the Froment book test, it is for the adductor pollicis. In this, we are actually checking the integrity of the adductor pollicis. In the paper test, we ask the patient to put a paper in between the fingers like this, and we pull the paper like this. When we pull the paper, we ask the patient that hold this paper, and we are actually checking the adduction of the fingers. So the adduction of the fingers is tested like this. If the patient is able to resist this pull, that means the adductor muscles of the fingers, that is the palmar interossei, it is intact. So this paper test is for the palmar interossei, which helps in the adduction of the fingers. Ogawa test is for the dorsal interossei. For the Ogawa test, we ask the patient, or we ask the patient to put the hand like this, and we resist, or we put a pressure on either sides of the hand, and we ask the patient to open up the fingers. So this is the abduction of the fingers, and this abduction of the fingers is by the dorsal interossei. So if the patient is able to do this movement, that means the dorsal interossei are intact, and therefore if the patient is not able to resist, is not able to do the abduction of the fingers like this, so that means the dorsal interossei, they are affected, which are supplied by the ulnar nerve. So these are the tests for the ulnar nerve. Now in this only we should be able to say that what is the sensory supply of ulnar nerve in hand. Now the ulnar nerve in the hand, it is supplying the medial 1.5 fingers and the adjacent palm. And this is on the palmar side also and on the dorsal side also. So it is on the both sides. So when we see towards the medial side, this medial 1.5 fingers and the adjacent palm, it is being supplied by the ulnar nerve. And when we see towards this posterior aspect dorsum, that over here also the 1.5 portion fingers and the adjacent palm, it is also the adjacent dorsum surface of the hand, it is also supplied by the ulnar nerve. So the ulnar nerve is supplying on either sides of the hand. So over here, the answer for this question is D, that is the ulnar nerve. Now we come to the next question, the question number 184. Question number 184, over here we have to identify the culprit muscle in the sleep apnea syndrome. Over here if we see, this is a picture which is actually showing the muscles of the oral cavity or the muscles of the tongue. Now if we try to identify this A, B and C, the A structure which has been mentioned over here, it is the styloglossus muscle. This process, which is bony process, is a styloid process. This is the styloid process, and the muscle which is coming from the styloid process and it is going towards the posterior aspect of the tongue is shown as A over here, and this A is styloglossus muscle. This is the styloglossus muscle. Then if we see the B structure, the B is marked over this quadrilateral muscle, and if you see, this quadrilateral muscle on the lower end is attached to this hyoid bone. This is the hyoid, and it is specifically attached to the greater corner of the hyoid as well as to the body of hyoid, and above it is going and getting attached to the tongue. This muscle is the hyoglossus muscle. So B is the hyoglossus. Then if we come towards the C, it takes origin from here. This is the section of the mandible. This is the mandible, and this point is the superior genial tubercle. Then the muscle, it fans out and it forms a major component of the tongue. Only the inferior most fibers are the one which will go towards the hyoid bone. This muscle is marked as C over here, which is the genioglossus muscle. Now the D structure which has been mentioned over here, this D structure, the muscle is coming from this point like this. This point is the posterior most border of the palate, hard palate, and then it is coming towards the tongue. So this muscle is palatoglossus muscle. So these are the muscles of the tongue, the styloglossus, hyoglossus, genio and the palatoglossus muscle. So when we talk about the tongue, the muscles of the tongue, we are having 4 muscles. The 4 extrinsic muscles are there, and they include the genioglossus, which is the major muscle of the tongue, and this is the muscle which is forming the major mass of the tongue, and it is termed as the safety muscle of the tongue. And this is the muscle which helps in the protrusion of the tongue. Another muscle, the styloglossus, it retracts the tongue and as well as it pulls it upwards. The third muscle, hyoglossus, it makes the dorsal surface of the tongue convex. Then the fourth muscle is palatoglossus. This muscle, it is actually guarding or it is closing the oropharyngeal isthmus. Now over here the genioglossus muscle, it is helping in the protrusion of the tongue, and it is considered as a safety muscle of the tongue, and it is forming the major mass of the tongue. So if there is, this is the muscle which is actually responsible for the obstruction in the sleep apnea syndrome. When this muscle is not functional or during the sleep apnea syndrome, the muscle, the tongue will fall backwards and it will close the airway pathway. Over here we can see in this picture. This picture is showing the obstructive sleep apnea syndrome. The muscle which is forming the major component, this whole the major component over here, it is formed by the genioglossus, and it prevents the falling back of the tongue. So therefore we say it helps in the protrusion of the tongue. So during the sleep apnea, the tongue will fall backwards, the trunk fall backwards, and it obstructs the airway. So we can see over here the tongue is falling backwards and the airway over here is obstructed. The air which is coming from here, now the lumen is very less so as to go downward. So it is obstructing the airway. So the genioglossus is the muscle which is actually participating, or due to which there is obstructive sleep apnea. So if we come back to the question, the culprit muscle in the sleep apnea syndrome, it will be the genioglossus muscle. So the answer for this question will be C. Now question number 185. The question number 185 says, when an ulcer damages an artery supplying the area of the greater curvature of the stomach, which artery will be involved? The answer for this question is D, that is the right gastroepiploic artery. Now for this we will just discuss the the arterial supply of the stomach. When we talk about the stomach, this is the lesser curvature, and this is the greater curvature of stomach. Now the arteries which are present or supplying the lesser curvature of the stomach, it includes the left and the right gastric arteries. This is the left gastric artery, and this left gastric artery, it is a branch of celiac trunk. The celiac trunk is one of the branches of the abdominal aorta which is arising from the anterior aspect, and this left gastric artery is supplying the uppermost portion of the lesser curvature. If we see towards the lower side for this, for the lower aspect of the lesser curvature, it is supplied by the right gastric artery, and this right gastric artery, it is the branch of hepatic artery proper. Now towards the greater curvature, again the uppermost portion is supplied by different artery, and this lower portion is supplied by the different artery. This is the left gastroepiploic artery. This left gastroepiploic artery is the branch of splenic artery, and it is the left gastroepiploic artery is the one which is supplying the superior aspect of the greater curvature, and towards the lower side, the inferior aspect of greater curvature is being supplied by the right gastroepiploic artery. The right gastroepiploic artery, it is a branch of gastroduodenal. Now among this, if we see the right gastroepiploic artery is the one which is present most nearer to the pyloric sphincter around, and when we talk about the ulcerations they are usually present around close to this pyloric sphincter or 4 centimeter from the pyloric sphincter, and it is mainly towards the greater curvature. So if there is the presence of ulcers over here, the artery which will be involved will be the right gastroepiploic artery. So if we come back to the question, so therefore the answer for this question is D. It is supplying the greater curvature as well as it is supplying that area of the greater curvature which is more prone to the ulcers. So it will be damaged if the ulcer is present. Now question number 186, It is regarding the facial nerve. Now first of all we will just discuss the facial nerve. Now the facial nerve, the seventh cranial nerve, it is actually rising at the pontomedullary junction. And after it arises from the pontomedullary junction, it will pass through the internal auditory meatus and it will reach towards the petrous part of the temporal bone. So if you see this course of the facial nerve, this is the course for the facial nerve. It is having two roots, the motor root and the sensory root. The motor and the sensory root, they pass through this meatus which is termed as internal auditory meatus. It is passing through this internal auditory meatus along with the labyrinthine vessels and the eighth cranial nerve, that is the vestibulocochlear nerve. Then as it reaches or it is passing through this canal, the internal auditory canal, the motor and the sensory root, they will combine to form the facial nerve. Now due to this presence, it is divided, the facial nerve is divided into three parts. First part is the intracranial part. First part is the intracranial part, and this is the first part beginning from the origin till it enters the internal auditory meatus. So this is the first part or the intracranial part. Second is the intrapetrous part. The intrapetrous part is that part of the facial nerve which is actually traversing through the petrous part of the temporal bone. First of all, it is related to the inner ear. That part is termed as the labyrinthine part. This is the labyrinthine part which is related to the inner ear going till here. Then as it reaches towards the middle ear cavity or the tympanic cavity, it is having a collection of the neurons over here, and this is termed as geniculate ganglia. It takes a turn and it goes posteriorly. This portion over here, this is termed as the tympanic part, and then it reaches towards the posterior wall of the middle ear, and as it descends downward in the posterior wall of the middle ear, this is termed as the mastoid part. Now this whole part extending from this internal auditory meatus, this whole part from here till this part, this is termed as the intrapetrous part, and then this intrapetrous part, it exits the cranial cavity through the stylomastoid foramen. So again, if you see over here, the intrapetrous part, this one second part, it extends from the internal auditory meatus till the stylomastoid foramen, and this is the part which is traversing through the petrous part of the temporal bone. It is again divided into three portions as we have just discussed: the labyrinthine part, the tympanic part, and the mastoid part. This is the labyrinthine, then tympanic, and the mastoid. The third part of the facial nerve will be the extracranial part. This is the part when it exits the stylomastoid foramen and it comes out towards the face. So this part extending from here till this is the extracranial part. Now when we talk about the branches of the facial nerve, three branches are given off by the facial nerve in the intrapetrous part, and the first branch is the greater petrosal nerve. So over here if you see, this is the first branch. This is the first branch of the greater petrosal nerve. This is the first branch of the facial nerve, which is greater petrosal nerve, and it is given off at the point of geniculate ganglion, and this is the first branch of the facial nerve. So this is first branch, greater petrosal nerve. Now the second branch which is given off is over here, and this is the nerve to stapedius. So second branch which is given off is nerve to stapedius. The third branch over here, just before it is coming out through the stylomastoid foramen, is given, which is the cauda tympani. So this is the third branch, the cauda tympani. Now these three branches are the one which are given within the middle ear only, and the rest of the branches will be given when it exits out through the stylomastoid foramen. So now we come to the rest of the branches. The rest of the branches, over here it is given, one is given over here. This is nerve to the posterior belly of digastric and nerve to the styloid. Then as it goes further, it will be passing through the substance of the parotid gland, and it will be dividing into these terminal branches. So this one is the fourth, nerve to digastric, the nerve to posterior belly of digastric. This one is the fifth, nerve to styloid, and these are the terminal branches. Now over here we can see the greater petrosal nerve. If we focus on the greater petrosal nerve, this is the branch which is the first branch, and it is given proximal to the nerve to stapedius. Now this was the question this is the point which is being asked in the question, that greater petrosal nerve, it is given off proximal to this nerve of stapedius. Now apart from these parts, cores, as well as the branches of the facial nerve, we should be able to talk about the functional components also. When we talk about the nuclei and the functional components of the facial nerve, we are having four functional components. We are having two efferent components and two afferent components. If we talk about the efferent components, the SVE and GVE, then two afferent components are there, SVA and GSA. Now first of all we will talk about the efferent components. The SVE, or the special visceral efferent, it is the one which is actually developed from the pharyngeal arches, the second pharyngeal arch, and this is the component which arises from the motor nucleus of the facial nerve. This is the motor nucleus of the facial nerve, and it will be supplying the facial muscles. Apart from the facial muscles, it is also supplying the styloid muscle, then stapedius muscle, and the posterior belly of digastric. So the facial muscles, it will be supplying all the muscles, the facial muscles, the posterior belly of digastric, the styloid, and stapedius. Now the second component which has been mentioned over here is the GVE component. This is regarding the secretomotor supply of the various salivary glands or the glands which are present in the head and neck system, the parasympathetic fibers which are being carried. Now if you see over here, the nucleus which are responsible over here is two nucleus, the superior salivatory nucleus and the lacrimatory nucleus. SSN is superior salivatory nucleus, LN is lacrimatory nucleus. The superior salivatory nucleus, it is the one which gives off the preganglionic parasympathetic or the secretomotor fibers, which will reach over here. We can see it is reaching over the submandibular ganglion. This is the submandibular ganglion, and then the postganglionic fibers, they will reach towards the submandibular and the sublingual gland, therefore causing its secretion of the saliva from here. Another set of fibers, the preganglionic fibers arising from the lacrimatory nucleus, it reaches the pterygopalatine ganglion. This is the pterygopalatine ganglion, and the postganglionic fibers, they pass through the zygomaticofacial branch of the maxillary nerve. They reach towards the lacrimal nerve, and it will be supplying the lacrimal gland and will help in the secretion of the lacrimal gland. So these are the GVE or general visceral efferent columns for the facial nerve. When we talk about the afferent columns, we have special visceral afferent, that is carrying the taste sensation from the tongue. The taste sensation from the tongue, the entire 2/3, it is carried by the cauda tympani nerve. The cauda tympani nerve, it carries taste sensation from entire 2/3. And this taste sensation, the fibers are passing through the geniculate ganglion. Over here we can see the fibers are passing through the geniculate ganglion and it reaches towards the nucleus tractus solitarius. NTS is nucleus tractus solitarius. Now apart from cauda tympani, the greater petrosal nerve, it is also carrying taste sensation from the palate. So greater petrosal nerve, it carries taste from palate. So therefore both the cauda tympani nerve and the greater petrosal nerve, they are carrying the SVA fibers. If we talk about the specific nerves which are carrying the GVE fibers, which we have just discussed, for the submandibular and the sublingual gland, the nerve which is responsible over here is the cauda tympani, and for the lacrimal gland, the branch which is responsible is the greater petrosal nerve. So over here we can see these two branches, the cauda tympani as well as greater petrosal nerve, they are carrying two type of fibers. It is carrying GVE fibers as well as it is carrying SVA fibers. The fourth functional column is the GSA. The GSA, it carries the sensation from the skin of the ear, and the fibers, they are passing through the geniculate ganglion and then they finally reach to the spinal nucleus of the trigeminal nerve. So these are the various columns which are for the functional columns which are for the facial nerve as well as the nucleus and the specific nerves which are responsible for carrying these fibers. Now if we come back to the question, for the question number 186, in this we have to choose the correct statement. The A option is greater petrosal nerve is arising distal to the nerve of stapedius, which is not correct, which we have just discussed. It is arising proximal to the nerve of stapedius. Then cauda tympani, it consists of general somatic efferent fibers, which is also wrong, because the cauda tympani nerve, it is as we have just discussed over here, the cauda tympani nerve, it is carrying the GVE fibers as well as SVA fibers. So GVE plus SVA, they are carried by the cauda tympani. Now the option C is posterior belly of digastric is supplied by the general visceral efferent column. This is also wrong because it is carried by special visceral efferent column. The option D is the cauda tympani, it contains general visceral efferent as well as special visceral efferent fibers. This is correct as we have just mentioned. So the answer for this question is D. Now question number 187, it is regarding the ulnar nerve lesion. When we talk about the ulnar nerve, as we have already discussed regarding the ulnar nerve, we have discussed regarding the ulnar nerve. When there is lesion of the ulnar nerve, apart from these points, the supply of the ulnar nerve, the course of the ulnar nerve, the branches, then these are the three tests of the ulnar nerve which we have discussed, and the sensory supply. Then if we talk about the lesion of the ulnar nerve, when there is lesion of the ulnar nerve, it leads to the partial claw hand or the ulnar claw hand. The partial or the ulnar claw hand means when we talk about the claw hand is like this. But because this is partial claw hand, they will be clawing of these medial most two fingers only, because the tendons, the flexor digitorum profundus tendon of these two fingers are affected as affected. So the partial or the ulnar claw hand, it involves the little as well as the ring finger only. And apart from this, we are having the vesting of the intrinsic muscles of hand. The hypothenar muscle vesting will be there. So this is a characteristic feature of the ulnar nerve lesion, that is the presence of the partial or the ulnar claw hand is there. Apart from this, there is a ulnar paradox. The ulnar paradox, it says that if the lesion is at the lower level, the lesion is at lower level, then the claw hand, it becomes more severe. When we discuss regarding the lesions of any nerve, we say that if the lesion is at the upper level, there is more severity of the deformity, and as we go towards the lower side, the deformity or the symptoms, they decrease. But it is opposite in the ulnar nerve. As the lesion is going downwards, as there is a lower lesion, the claw hand, it is becoming more severe. So that is why we have used the term ulnar paradox. That is, the lesion at the lower level, the claw hand is more severe. Now why is it so? If we come back to this diagram, if this is the level of lesion over here, it will lead to the claw hand, because there is involvement of the flexor digitorum profundus, as well as it is involving the intrinsic muscles. The intrinsic muscles, the lumbricals of the medial side, the two lumbricals, as well as the interossei muscle, they normally help in the flexion of this metacarpophalangeal joint and extension at the interphalangeal joint. If these muscles are involved, we have this claw hand like this. This claw hand is there, in which there is extension at the metacarpophalangeal joint and the flexion at the two interphalangeal joints. Now what happens if the lesion is at the lower level? This is the lower level lesion over here. In this we can see this flexor digitorum profundus muscle, it is spared. If the lesion is at the lower level, this muscle is spared. And when we say the claw hand is there, because the flexor digitorum profundus of these two fingers is spared, it will cause the more flexion of these two fingers. So therefore, there will be more severe partial claw hand will be there. So this is the reason for the ulnar paradox. Now if we come back to the question says we have to choose the wrong statement about the ulnar nerve. A option says the claw hand is more marked in high lesion, which is wrong as we have just discussed. Then adductor pollicis is paralyzed, correct, because it is supplied by the ulnar nerve. Froment sign is also positive because it is testing the adductor pollicis muscle only. Then the sensory loss is on the dorsum of the fingers. As we have just discussed, it is towards the palmar side also as well as towards the dorsal side, and it is involving the medial 1.5 fingers. So this option is also correct. The answer for this question will be A. The next question is 188 question. Now for the 188 question, if we see the correct, if we see the question, which of the following statement is not true about a muscle which is not supplied by any branch of mandibular nerve, but from the main trunk itself? So we have to see that which is the nerve which arises from the main trunk of the mandibular nerve. When we talk about the mandibular nerve, the nerve as it is arising, it is actually passing through the foramen ovale, and after passing through the foramen ovale, which is present in the middle cranial fossa, it comes down in the infratemporal fossa region. In the infratemporal fossa region, as it comes down over here, it divides into two divisions, that is anterior and the posterior division. This is anterior division and this is posterior division, and this portion over here is the trunk of mandibular nerve. Now this trunk of mandibular nerve, it gives two branches. One is a branch which will go back towards the cranial cavity, and this is the nervus spinosus. Another is a branch which is to a muscle, that is nerve to medial pterygoid. nervus spinosus, and this is nerve to medial pterygoid. So these are the two branches which arise directly from the trunk. The nerve of medial pterygoid, as we can see over here, it is arising directly from the trunk. Now the anterior division over here, the anterior division will further give branches which will be supplying the rest of the muscles of the mastication, and so there will be masseteric nerve, the pterygoid branch is there, it is for lateral pterygoid, it is for the lateral pterygoid. Then we have temporal branch or the deep temporal nerves, and another is buccal nerve. Only this buccal nerve is the sensory, and rest of these are the motor roots or motor branches. The posterior division, it divides into three branches, and those are auriculotemporal nerve, then the lingual nerve, and third is inferior alveolar nerve. So these are the branches of the mandibular nerve, and if you see over here, the branch which is given off to a muscle and it is arising from the trunk, that is the nerve to medial pterygoid. So now we know that we have to look for the nerve to pterygoid in this question. So we come back to the question. If we identify the various structures which have been mentioned over here, the structure A is on this muscle, and this muscle is the buccinator muscle. A is the buccinator. The buccinator muscle, it is supplied by the facial nerve. Then the B structure which has been mentioned over here, this B structure, the B structure is lateral pterygoid. The B structure is the lateral pterygoid. The B structure which was written over there was the lateral pterygoid. And when we talk about the lateral pterygoid, it is taking origin, it is having two heads, and they are taking origin from infratemporal surface of sphenoid. So one head is taking origin from sphenoid, and another head is taking origin from this infratemporal surface, and another is taking origin from lateral pterygoid plate of sphenoid, and that to its lateral surface. These are 2 points of the origin. When we talk about the insertion, it is inserted on the pterygoid fovea, the pterygoid fovea of the mandible. The pterygoid fovea of the mandible, it is present just near or below the condylar process, and this is supplied by the mandibular nerve which we have just mentioned, and the branch of this is arising from the anterior division of the mandibular nerve. The C option which has been shown over in the picture is the medial pterygoid muscle. The medial pterygoid muscle, again it is having two heads of origin. So if we talk about the origin, it is having two heads. One is the superficial head and another is the deep head. The superficial head, it arises from the maxilla, and to be more specific, it is actually arising from the maxillary tuberosity of the maxilla. The deep head, it arises from the medial surface of lateral pterygoid plate. The insertion of this muscle is towards the ramus of mandible. Inner aspect. If we talk about the ramus of mandible, this is the ramus of mandible. On the ramus of a mandible, on the outer side, it is giving attachment to masseter muscle, and on the inner side, it is giving attachment to the medial pterygoid muscle. And this is the muscle which we have just discussed. It is getting supplied by nerve to medial pterygoid, which is coming from the trunk of mandibular nerve. The D structure which has been mentioned over here is the superior constrictor muscle, and this is one of the muscles of the pharynx, and it will be supplied by the vago-accessory complex. That is a vagus nerve and the cranial root of accessory nerve. Now if we come back to the question, if we come back to the question, in the question it says, for the question number 188, in this the A option says that the muscle is quadrangular and it is having two heads, the superficial and deep. So according to the question, the muscle which we are talking about is the medial pterygoid muscle, and it is a quadrangular muscle which is having superficial head and the deep head. So this option is correct. The B says that the muscle shown is C in the diagram, and this is also correct. Then option C says that the superficial head arises from the zygomatic bone, which is not correct. It is actually arising from the maxillary tuberosity of the maxilla. The D option says that this muscle, the medial pterygoid muscle, it helps in elevating and closing the mandible. If we talk about the action of this muscle, yes, it helps in the elevation of mandible. So when it elevates the mandible, it is actually closing the mouth. So this option is also correct. So the answer for question number 188 will be C. The muscle, the medial pterygoid, it elevates the mandible, and the muscle which is helping in depression of the mandible is the lateral pterygoid. For the side to side movement, again these two pterygoids, they are helping, medial and the lateral pterygoid. For the protrusion movement, the medial and the lateral pterygoid, and for the retraction of the mandible, we have the temporalis muscle. Now the next question is 189 question. The next question is 189. The 189 question, it is regarding all the features of ileum are true except. Now in this the answer is D. The answer is D for this. When we compare the features of ileum with the duodenum, now this is a picture which is showing the difference between the ileum and the duodenum. When we talk about the ileum is the part of the intestine which is present in the hypogastric region. So it is present in the hypogastrium. And if we compare it with the duodenum, the duodenal part of the small intestine, it is present in the umbilical region. Then another difference is that the duodenum, it is, the lumen is wider, and the lumen of the ileum, it is narrower than the duodenum. So lumen is less wider in the ileum, as well as it is less vascular than the duodenum. The wall thickness is also less. Apart from this, if we see the branching pattern, this is the branching pattern which is shown over here. In the duodenum, towards the duodenum side, if we see, this is the artery which is supplying the duodenum. Before supplying the duodenum, it will be forming these arterial arcades. These are the arterial arcades which are formed, and only one or two rows of the arterial arcades are formed, and after this it gives these vertical branches which are termed as vasa recti. These are the vasa recti which will be now supplying the duodenum at the mesenteric border. The area between the vasa recti over here, this is termed as windows. These are the windows, and because the fat is less in the mesentery of the duodenum, these windows will be transparent. If we compare it with the ileum, towards the ileum side, from the artery, the arcades which are formed, the arcades are more. There are at least 4 to 5 rows of the arterial arcades, and due to this the vasa rectae which are present over here, these are short. So the short vasa rectae are there. Now for the peritoneal windows, because there is more fat in the mesentery of the ileum, the peritoneal windows will be opaque. So for the ileum, more arterial arcades are there. Then we have short vasa recta and opaque peritoneal window. The opaque windows are there, and this is because more fat in mesentery. Apart from this difference, if we cut open the ileum and we compare it with the cut portion of the duodenum, we can see over here, this is the cut open portion, and on the inner aspect of the duodenum we can see these circular folds which are also termed as plica circularis or the valve of Kerckring. These circular folds, they are large and they are closely present or closely set. If we compare it with the ileum, the circular folds over here, they are at a distance, so we say they are sparse and they are shorter. So circular folds in the ileum, they are short and sparse. Apart from this, if we compare the lymphoid aggregates, in the duodenum the lymphoid aggregates, they are present in the form of small solitary nodes. Towards the ileum, the large lymphoid follicles are there and they are being termed as Peyer's patch. So these are the features which are present in the ileum, and if we come back to the question says all are the features of ileum except the presence of Peyer patch, then it occupies the hypogastrium and pelvic region. This is correct. 3 to 5 arcades are present. The circular folds are more numerous. The circular folds are actually less numerous in the ileum and they are sparse and short. So the answer for this question is D. The question number 190. For the question number 190, it says over here we have to choose the incorrect option. Now first of all we will identify the various structures over here. If you see over here, A is the deltoid muscle. Then the B structure over here is the cephalic vein. The B is the cephalic vein. C is the thoracoacromial artery. And the D structure which has been shown over here is pectoralis minor muscle. So for question number 190, when we talk about the A structure, that is deltoid, this is a structure which is actually supplied by the axillary nerve, and this axillary nerve, it arises from the posterior cord of brachial plexus. It is one of the branches of posterior cord of brachial plexus. Apart from supplying the deltoid, it also supplies teres minor. When we talk about the deltoid muscle, it is a multipinnate muscle and it is forming this the major portion of the shoulder. The origin is from the lateral portion of the clavicle and as well as from the acromion process of scapula and posteriorly from the upper lip of the spine of scapula. Then this whole muscle is coming down over here and the fibers, they converge over here at the deltoid tuberosity of the humerus. So this is regarding the deltoid muscle. Then the B option was cephalic vein. The cephalic vein is one of the superficial veins of the upper limb. As it traverses, it is actually traversing along the outer border or the lateral border of the arm, and as it reaches towards the shoulder, over here it pierces, it runs in this deltopectoral groove and then pierces the clavipectoral fascia to drain into the axillary vein. So it is forming one of the contents of deltopectoral groove. It is one of the content of deltopectoral groove. This deltopectoral groove is present between the deltoid muscle and the pectoralis major muscle. The other contents of this deltopectoral groove, it includes the deltopectoral lymph node as well as the deltoid branch of thoracoacromial artery. Then the C structure which has been mentioned over here is thoracoacromial artery. As we know, this thoracoacromial artery, it is a branch of the axillary artery and it specifically arises from second part of axillary artery. From the second part of axillary artery, thoracoacromial artery as well as the lateral thoracic artery, these are the two branches which arise from here. And the thoracoacromial artery, it further will divide into the deltoid branch, pectoral branch, acromial branch as well as the pectoral branch. The D structure which is mentioned over here is pectoralis minor muscle. The pectoralis minor muscle. The pectoralis minor, it is actually arising from 3rd, 4th and the 5th ribs, and it goes laterally and gets inserted over the coracoid process. Now because it is inserted towards the coracoid process, it is not causing any movement at the shoulder joint. It actually helps in the protraction of the scapula. It is assisting the serratus anterior for this movement, for the protraction. Apart from this, it depresses the shoulder, depresses the uppermost point of the shoulder. And it also acts as one of the accessory muscles during the forced inspiration. When we talk about the pectoralis minor, it is supplied by the medial and the lateral pectoral nerves, and these nerves, they are actually arising from the medial and the lateral cords of the brachial plexus. So if we come back to the question in this, we have to choose the incorrect statement. It says A, that is deltoid, is supplied by the posterior cord of brachial plexus. This is correct. Then B, that is cephalic vein, is content of the deltopectoral groove. This is also correct. C, thoracoacromial artery is a branch of second part of axillary artery. This is also correct. D, pectoralis minor is for internal rotation of shoulder joint, which is not correct. So the answer for this question is D. Question number 191, it says blood supply of duodenum. Now the blood supply of the duodenum, it is by the duodenal arteries, which are a branch of the superior mesenteric artery. So the answer for this question is B. For the whole of the GIT system, when we talk about the GIT system, it is supplied by 3 branches. One is the celiac trunk. It is supplying the structures which are derived from the foregut. Then another is superior mesenteric artery. It supplies the structures which are derived from the midgut. And third is inferior mesenteric artery, which will be supplying the structures derived from the hindgut. Now the junction of the foregut and midgut is at the level of major duodenal papillae in the second part of duodenum. So the structures which are derived till major duodenal papilla in the second part of duodenum. So till this point, all the structures of the GIT or derived from this foregut will be supplied by the celiac trunk. Then from this major duodenal papilla to the junction of right 2/3 of transverse colon and left 1/3 of the transverse colon. So we will just write over here transverse colon. Till this point, the branches are given to supply these structures which are derived from the midgut, and after this, the structures which are derived from the hindgut will be supplied by the inferior mesenteric artery. The superior mesenteric artery, it gives rise to inferior pancreaticoduodenal artery. Then it gives rise to duodenal branches and the ileal branches, iliocolic artery, middle colic artery, and the right colic artery. So over here we can see the duodenal artery or the duodenal branches, they are arising from the superior mesenteric artery, which will be supplying the duodenum. So therefore, if we come back to the question is the blood supply of duodenum is through the superior mesenteric artery. The question number 192, it says that fracture classification. This fracture classification is actually the Leeford classification. Shown in the image involves, it is involving over here the bone which will be present over here at this point. This bone is the zygomatic arch. The zygomatic arch, which is actually between the zygomatic bone over here and the temporal bone over here, the bony arch which is present over here is the zygomatic arch, and this is fractured over here in this picture. So it involves a zygomatic arch. Answer for this question is A. Question number 193, in this we have to see this pointed cartilage. This pointed cartilage, a pyramidal cartilage which is present just above the cricoid. This is the arytenoid cartilage, and it is derived from the 6th pharyngeal arch. So the answer is D. This picture is actually showing the posterior view of the larynx, and if you see the posterior view of the larynx, if this is the thyroid cartilage, it is having V-shaped lamina like this, and it is not present towards the posterior side. Just below this we are having this cricoid cartilage, this is cricoid cartilage, this is thyroid, and just above this posterior portion of the cricoid cartilage, another cartilage which is present, a pyramidal cartilage which is present over here, is the arytenoid. So the arytenoid cartilage, it can be viewed from the posterior side only, and it is present towards or lying above the posterior arch of this cricoid cartilage. Just near the apex of the arytenoid cartilage, which we are having two other cartilages, that is corniculate and the cuneiform. So therefore in this picture, the arrow is being marked over the arytenoid, and as we have discussed earlier, the various derivatives of different arches, the arytenoid cartilage, it is arising from the 6th arch, and therefore the answer for this question is 6th pharyngeal arch, that is D. This completes the anatomy questions for GT 183. Thanks to all of you.